hear me, just speak up, or if you've got questions, we're still a small enough group, you can feel free to interrupt me. Well, it's true I did graduate from Georgetown. I am heading back to my 30th year reunion in another couple of weeks, so I've done a few things in between that. I joined the staff at NewYork-Presbyterian a little over a year ago, but prior to that I was downtown at Beth Israel Medical Center for about 20 years. I'm a general neurologist. I like taking care of common neurological problems, and dizziness is one of them, so I'm happy to address you on this topic. No specific disclosures. So a little bit about dizziness. Dizziness is a really common but very vague complaint. By itself, you can't make a diagnosis when someone just says dizzy, and you can't really figure out treatment unless you know what's causing the dizziness. The doctor needs to help the patient place the symptoms into one of three really broad categories, and we're going to go through that. So syncope and presyncope, so that's fainting and near fainting. Unsteadiness and imbalance, so that's a walking problem. Vertigo and spinning. So if you're going to go to your doctor with symptoms of dizziness, I want you to think about your dizziness a little bit so you can give the doctor more tools so they can help you diagnose the problem and come up with the appropriate therapy. When I'm evaluating a patient whose complaint is dizziness, the history is the most important part of the evaluation. So when people say they're dizzy, I say, so what do you mean? Do you feel like you're going to pass out? That's a lightheaded symptom, and usually associated with near faint or fainting spells. Did you feel like you were spinning or that the room around you was spinning? Or do you feel unsteady, walking like you're drunk? That being said, lightheadedness is not always near syncope. Vertigo is not always an inner ear problem. So it's our job to figure out what else is going on. When somebody first complains of dizziness, we rule out the common stuff. Is your blood count low? Are you hypoglycemic? Is your blood sugar through the floor? Is there a thyroid problem? Are you dehydrated? Have you been out in the sun not drinking enough? Have you been nauseous and throwing up and having diarrhea, not replacing your fluids, and then you feel dizzy? Well, of course you feel dizzy. You're dehydrated. Is your blood pressure low? We go through medications. A ton of different medicines can cause lightheadedness or dizziness. Some of the anti-seizure medicines, some of the antidepressant medicines, medicines that help with urination, and obviously blood pressure medicines can all cause dizziness. I saw a patient in this week who I had seen a month ago who came in with dizziness, very sweet older guy in his mid-80s, could barely walk because he was so hobbled by his dizziness. When I examined him, his blood pressure went from a nice 110, 120 systolic when he was lying flat. When he stood up, his blood pressure dropped to 75. Well, duh, he was dizzy. He's been on a medicine to help with his prostate. We took him off the medicine. He came maybe not skipping down the hall to see me this week, but a lot better. Hasn't had a fall, hasn't been dizzy. He pees a little bit more. We'll deal with it. Anxiety and hyperventilation, another really common cause of dizziness. When someone comes into the ER and they're dizzy, there's usually 4 different ways you can go. If it's vertigo, spinning dizziness, they get sent to ENT. If they feel like they're nearly fainting or they actually faint, they go to the heart doctors. If they feel unsteady on their feet, they get sent to me, Neurology. And if they're non-specific dizziness, we usually send them off to the psychiatrists. That being said, almost everybody ends up coming to see Neurology at some point. Excuse me one second, I'm the doctor in the hospital. Hello? Need to be cloned. So why do we have trouble diagnosing dizziness? Because many patients have a lot of trouble describing what they mean. Doctors don't actually agree on the terminology. And the categories of dizziness, what category, what slot we kind of slot the patients into, don't necessarily predict pathology. The other thing I like to really talk to my patients about with dizziness is the time course. Do they have a single bout of dizziness that lasts a few days? Do they have recurrent bouts of dizziness, or is it ongoing and continuous? And that's going to help me with my diagnosis. I also like to ask about associated symptoms. Do they have any ear symptoms? Hearing loss, ringing in the ears or tinnitus, pain or pressure or fullness in the ear. Those symptoms are going to be more like an inner ear problem, and the ENT doctors might help us out. Do they have headaches? Specifically, do they have a history of migraine, or a lot of patients in the family that have migraine? Because vertigo is really common in migraine patients, so that's another thing we'll talk about. Do they have other neurological symptoms that are more concerning? Do they see double? Is their speech slurred? Is something in their face numb or tingling? We'll get to what those imply a little bit later. So where do these patients end up? What do you see when you look at about 100 patients? About a third of them have vertigo. It's often benign positional vertigo. It could be an inner ear problem. It could be Meniere's disease. About a third are going to be lightheaded. They could be hyperventilating, have psychogenic lightheadedness, or every once in a while you have a problem with your thyroid. Could be disequilibrium, so instability, multiple sensory deficits. They don't hear well, they don't see well, they don't feel well. Any of those things are going to make you a little bit unsteady on your feet. They could have a problem with the brain, so they can have hydrocephalus, and that gives you frontal lobe ataxia. So that just means the frontal parts of your brain aren't working well and they make you unsteady. It could be Parkinson's disease. Chronic double vision can make you unsteady on your feet. Are they having near syncope, near fainting spells? So drop in blood pressure when they stand up, orthostatic hypotension, and every once in a while someone will faint when they're peeing, micturition syncope. So in one study, this is what they came up with. My job is to actually examine the patient. So I do a neurological exam. In addition to doing the basics, like taking blood pressure, and I check blood pressure in either arm, I check blood pressure when people are lying down and standing up. We look at the ears, we do a hearing test, we do a Romberg test. Anybody know what a Romberg test is? Okay, you go to the doctor, you stand with your feet together, and you're asked to close your eyes. And what we're looking for is that people can hold their balance with their eyes closed. If you have bad sensation in your feet, when you close your eyes, you fall over. If you have an inner ear problem and real vestibular dysfunction, even standing with your feet together and your eyes open, you often lose your balance. So that's very helpful. We do tests of cerebellar function. So if you go to the doctor with dizziness, they're going to do all these things. Finger to nose. So I want people to touch my finger, touch their nose, touch my finger, touch your nose. We want to see it accurate. If you're always off to one side, that's called pass pointing. That's a sign of a problem in the cerebellum, the back of the head. Tandem gait, walking a straight line to see if you're drunk. We do eye movements. Eye movements are really important. Following my finger back and forth, looking up, looking at my nose and looking at my finger. Can you do that in a nice straight line, or do the eyes jiggle when they go from one side to the other? We do something called a head hanging test and a head impulse test, and we're going to get to those in a little bit. So don't be surprised when your doctor does weird stuff when you complain of dizziness. So the head hanging test, or a positioning test, also known as a Baronate maneuver and also called a Dix-Hallpike maneuver, and it's really important when we're looking at patients who have dizziness or vertigo. In addition, it's actually a treatment for benign paroxysmal positional vertigo. And the idea of the test is to make the little stones in your ears, the otoconia, move, and it will actually induce vertigo and nystagmus. And what I do with the patient is I have them sitting on the side of the bed, I hold their head, I tell them what I'm going to do, and you bring them back and at an angle. And if they have benign positional vertigo, we'll get to that diagnosis in a second, they will probably hit me, they will scream that they've got vertigo, and they will hang on to the bed for dear life. Most of my patients don't love this procedure. I actually do more of a modified procedure where I just have patients lie flat on the bed. I turn their head to one side and have them look down through the table. I find that's almost as good in terms of making a diagnosis, and it's a little less extreme. We also do something called a head impulse test. And this is another test of visual focus. I have somebody stare at my nose, sitting up, staring at my nose, turn their head about 15 to 30 degrees, still staring at my nose, and then rapidly bring their head back. I want their eyes to stay on my nose. If their eyes are jiggling all over the place, that's another sign that there's an inner ear problem. There's some other diagnostic testing that the ENT doctors like to do. Electronystagmogram and video nystagmogram that assess eye movements, sometimes with challenges like putting cold water in the ears and sometimes with head turning. They use a special eyeglass that can monitor the eye movements. The problem with these tests is that they're often non-diagnostic. So I will have patients who go to ENT with dizziness. They have one of these tests and the tests come back non-diagnostic. Maybe it's an inner ear problem, maybe it's a brain problem, you better see the neurologist. I find them almost useless and incredibly uncomfortable. One person's opinion. And there's a few others that they do. And I think they're all kind of similar in terms of value. So let's talk about the different kinds of dizziness we've got. A swoon, a faint, or a near faint. That's our syncope or pre-syncope. Fainting is a brief, sudden loss of consciousness with an inability to maintain postural tone. That means they fall down to the ground, followed by spontaneous recovery. You wake up right away. And it means that the blood flow to the brain has been interrupted for about 10 seconds. If the blood flow to the brain is limited for less than 10 seconds, you get near syncope, so near faint, but you don't actually faint. Syncope is a word derived from two Greek roots. Syn, which is an intensifier meaning at once, and kopton, which is a verb meaning to cut or to strike. And the term syncope refers to the actions of the three fates of Greek mythology who spun out and cut short the thread of each person's life. And here are our three fates, cutting our strings to make us faint. Neurocardiac or vasovagal syncope is the most common of the reflex faints. And it's a sudden failure of the autonomic nervous system to maintain blood pressure and sometimes heart rate high enough so that your brain is being perfused. This is the faint that occurs when you are frightened, when you see blood, or when you have sudden visceral pain. So sudden abdominal pain, it sets off a reflex arc where your blood pressure drops and you actually faint. It's one of the most common causes of fainting, and it's an overreaction of the body to certain triggers. Emotional stress, those are the people who faint when they're upset, pain, the sight of blood. And again, the triggers will cause a sudden drop in the blood pressure and the heart rate. The brain isn't getting enough blood, and the brain goes to ground to get more blood, and that causes a loss of consciousness. It is usually harmless, but it will set up a whole bunch of diagnostic studies. In general, people don't need to see a neurologist for vasovagal syncope. It's a reflex problem, it's not a huge issue. The big differential is whether or not they had a seizure, and most doctors can kind of figure that out. I tend not to do any tests on someone I see who comes in after a faint. You don't need an MRI, you don't need Doppler studies, you usually don't even need a heart monitor. It's kind of just being reassured. A lot of people will come in with dizziness because they have pre-syncopal symptoms, so near faint. These symptoms progress a little bit more slowly, and they come on over minutes or even a little bit longer. So people will feel hot or sweaty, a little bit flushed. They often have a dry mouth. They feel short of breath, like they're starving for air. They yawn. Some people will get belly pain, abdominal distress. The vision can get sparkly or dim. The ears can sound muffled and far away, and people will say they feel lightheaded. What I commonly see is patients will get this when they're sitting up or they're in a crowded area, and they say, I'm just going to go out for a little bit of air. The problem with that is that they don't make it out for the air. If you get symptoms like this, you can't fight through it. You can't tough it out. If you get up to try and get air or try to get to the bathroom to put water on your face, chances are you're going to faint on the way to doing that. What you want to do is, if you get lightheaded, is lie flat. It's not that helpful to put your head between your knees because it's still really hard for the heart to pump blood that fashion. You want to go flat. If you don't go flat, your body's going to do what it needs to do to get blood to the brain, and that's going to be go flat. That's how you end up fainting. All right, any questions about vasovagal syncope, lightheaded, near syncope, near fainting before we go on to the inner ear? Okay, so let's talk about the vestibular system. So the vestibular system is your balance system. Okay. It is deep inside the head, inside your temporal bone. Whoops. That's not what I wanted to do. Okay, so when the ear doctor or your internist looks in the ear, so they're looking in with their otoscope, unless they're getting past your tympanic membrane, your eardrum, they don't see that. So the fact that the ENT doctor will look in your ear and say there's nothing the matter does not mean it's not a vestibular system, a vestibular dysfunction. They can't see it. So the, actually this we're not even going to discuss because this is just Hamlet. The vestibular system is the inertial guidance system. The vestibular organs, so these organs inside the inner ear, transduce the forces that are associated with head acceleration and gravity into a biological signal that the brain can interpret. The brain uses the signal to develop a subjective awareness of head position, so where your head is in space, and produce motor reflexes for equilibrium and locomotion. So when you turn your head or lean to one side, your body knows to compensate so you don't fall over. The vestibular system consists of 5 organs that are located within the labyrinth cavities of the temporal bones of the skull. Again, deep within the skull. You've got 2 organs, the saccule and the utricle, that sense linear acceleration, so going forward. You've got 3 semicircular canals that sense angular acceleration, so turning the head, bending the head, going up and down. The semicircular canals are the 3 little canals that are located at right angles to each other, and they're filled with this dense fluid called endolymph. When your head rotates, the endolymph fluid lags behind due to inertia because it's thick. That tugs on the little hair cells inside the inner ear, inside these semicircular canals, that sends signals to the brain so you know where your head is in space. The hair cell, the little hair cells, these little tiny organisms inside your vestibular organs are the basic element of hearing and motion. They transduce the mechanical force into a nerve action. The nerve action goes to the brain and you interpret where your head is in space. The symptoms of vertigo, this motion sensation of dizziness, are caused by an imbalance of the normal resting activity of the receptors. Does that make sense? So we have constant motion telling us where we are in space. If there's an imbalance, so one isn't working and one is, you feel like you're moving. And these are, again, our vestibular organs deep inside the inner ear. And little hair cells. and little crystals in the ear that are floating in the endolymph. This is how we actually keep our balance. So when we talk about peripheral vestibular disorders, so peripheral means it's outside the brain, but involves the inner ear structure. We've got a bunch, and we're going to go through them in sequence. There's benign paroxysmal positional vertigo, there's acute vestibular dysfunction, there's Meniere's syndrome, there's chronic vestibular dysfunction, and then there's a bunch of other stuff. So benign paroxysmal positional vertigo is a really common form of vertigo that's very disabling. It's vertigo, so spinning dizziness, that occurs suddenly with a change in position. Keep in mind that the title of the disorder is benign. So that means it's not dangerous. It just scares the bejeebers out of people and is really uncomfortable. The otoconia, those little crystals of calcium carbonate that are in the inner ear, detach and get clogged in one of the semicircular canals. When the head moves, those little crystals shift and you feel an abnormal sense of vertigo. Usually we can diagnose benign positional vertigo by that Dix-Hallpike maneuver, that position where you go backwards and you turn your head. And again, you can even do it in a more modified position. If I hear that someone always gets vertigo, dizziness, when they roll over in bed, when they're backing up the car and they look over their right shoulder, when they go back in the hairdressers, when they go down and then up and things go, I'm pretty sure they've got benign positional vertigo. I can test them by doing that procedure in the office. Usually after a second or so, we see dizziness, vertigo, and the eyes go jiggle, 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 often in a rotary position. So they go jiggle, 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 and that's a sign to me that they've got benign positional vertigo. If I could keep their head in that position, the vertigo would eventually resolve. Most of my patients are very uncomfortable in that position, so they don't wait that long, so they keep on coming back to the middle. And if I kept on doing the procedure, eventually it would fatigue. Most of my patients aren't going to allow me to do that more than once. Now we can do that same maneuver, that Dix-Hallpike, if you call it something different, the Epley maneuver, it's a way of treating benign positional vertigo. And again, you lie the patient back quickly with their head turned and essentially declogs the little crystals that are in the inner ear. And you can actually look this up online if you have benign positional vertigo, and they will give you instructions how to do it yourself. I tend to send people to vestibular therapy. Vestibular therapists tend to be extremely kind people. They're very nice, they're very supportive, and it's a lot more comforting for patients to do that in a therapeutic environment. The information from the inner ear is carried to the brain through the vestibular cochlear nerve. Now you can see the nerve coming out, and you can see that there's two components to the nerve, vestibular and cochlear. So it takes care of vertigo, that's the vestibular part, and it takes care of hearing, that's the cochlear part. You can see it here on the MRI, actually, yeah, on the MRI. And it's coming out of the brain at the bottom, but you don't need to know all that anatomy. Sometimes there can be inflammation of the vestibular cochlear nerve that causes conditions called vestibular neuronitis or labyrinthitis. And these are disorders that affect that complex nerve. Again, the vestibular cochlear nerve, a compound nerve responsible for transmitting information from the ear to the brain about balance, head position, and hearing. When the nerve becomes inflamed or swollen, it disrupts the flow of information and it gives you a variety of symptoms. If you just have involvement of the vestibular portion of the nerve, you get what's called vestibular neuronitis, sudden onset of relatively severe vertigo and dizziness, balance problems, dizziness, nausea, vomiting, and because they feel really awful, a lot of patients will have trouble concentrating. If you have labyrinthitis, it's very similar to vestibular neuronitis, but involves both portions of the nerve. So in addition to having vertigo, you also have hearing loss and often have ringing in the ear, because both components are affected. Most of the time, the severe symptoms just last for a few days, but they could be really severe enough to interfere with activities of daily living. People have trouble getting out of bed, they can't care for themselves, they have trouble walking, they're nauseous, they're puking, it's terrible. But they usually improve. Severe symptoms improving over days, and more mild to moderate symptoms improving over weeks. Unfortunately, some people will be left with chronic symptoms of dizziness and imbalance. Most likely, we think these syndromes are caused by a viral infection, either a virus that directly affects the inner ear, viruses or post-viral syndromes that cause swelling of the nerve, similar to like a Bell's palsy, where we sometimes think there's a direct virus affecting the nerve, but oftentimes it comes after a viral infection and the nerve swells independently. And sometimes there's a virus someplace else in the body that secondarily causes vertigo. And we see this with herpes viruses, measles, the flu, mumps, and even hepatitis. Usually we make the diagnosis clinically. It's through the history and the examination. If there's labyrinthitis, sometimes a hearing test is helpful. And if there's persistent symptoms or concern for another reason, we can do an MRI of the brain with and without contrast. That's usually going to be normal. We manage it symptomatically. So anti-nausea medicines are really helpful, like Reglan or Zofran, and medicines that suppress the vestibular system. So that's meclizine or Antivert, other antihistamine type medicines, and benzodiazepines like Valium and Ativan. I find that Valium is my best, or is really my go-to vestibular suppressant. It's a little bit fatiguing, but it tends to work more strongly than Antivert. Antivert makes people tired, tends not to help the vertigo all that much. When the symptoms are acute, we often give corticosteroids, so prednisone or a Medrol dose pack. If you're really concerned that this is a viral syndrome, if there's fever, or if there's rash, especially in the ear, or behind the ear, or in the back of the throat, we'll often give an antiviral medication. And again, most patients, 95% of patients, will improve. Meniere's syndrome is another common cause of vertigo. It's a disorder of the inner ear and causes recurrent symptoms. Vertigo, hearing loss that tends to fluctuate, tinnitus, so ringing in the ear, and a fullness or pressure in the ear. And it usually comes in episodes. Some people will have chronic Meniere syndrome, where they have persistent deficits, but most people have fluctuating symptoms over time. It usually affects one ear, rarely can affect two ears, and the symptoms can last anywhere from 20 minutes to a day or even more. It's more common in people in young adulthood, their 40s and 50s. What causes Meniere syndrome? We don't really know. We think it's some kind of abnormal volume of the fluid in the ear or an abnormal composition of the fluid in the ear, which is why it's often treated with diuretics, medications that make you urinate and reduce fluid, and through a low-salt diet. In terms of potential causes, sometimes we think there's a blockage in the drainage, or there's an anatomical abnormality of the inner ear, an abnormal immune response, allergies, viruses, a genetic predisposition, head trauma, or even migraine. In my opinion, I think when you have this many disparate potential causes, That essentially means that the doctors are not entirely sure what causes Meniere's syndrome. To make a diagnosis of Meniere's syndrome, you need to have 2 spontaneous episodes of vertigo that last for more than 20 minutes. You need hearing loss that's verified by a hearing test on at least 1 occasion, associated symptoms of tinnitus, so ringing in the ear and fullness of the ear, and you need to exclude any other cause. Medications, again, we treat it symptomatically. So the acute therapies are our vestibular suppressants, so Antivert or Meclizine, and benzodiazepines like Valium and Ativan, and anti-nausea medicines. For chronic Meniere syndrome, often patients are given diuretics, so again, medicines that help you urinate out the extra fluid. There's some other non-invasive therapies that can be helpful. Vestibular rehabilitation, which are exercises to help retrain the vestibular system. If there's hearing loss, you could get hearing augmentation with the hearing aid. And there's a device that applies little pulses of pressure to the middle ear called a Minette device, and that's also been shown to be effective. Every once in a while, patients will be very unresponsive to these initial therapies, and they need more aggressive therapy. So you can do a middle ear injection of things like gentamicin. It's an antibiotic that's actually toxic to the inner ear, and it reduces the function of that inner ear. It can increase your hearing loss. Corticosteroids or steroid medication could also be injected in, and that tends to decrease inflammation. Sometimes patients are given the option of surgical interventions. So endolymphatic sac procedure, so they go into the inner ear and actually open up the sac in the inner ear and drain some of the fluid. If their symptoms are so severe that they really can't function, they can actually destroy the vestibular nerve, section the nerve surgically, or they can remove the labyrinth, they can remove the inner ear structure. Now obviously if you're removing these things, you're going to have trouble with hearing. There are also lifestyle modifications that can be helpful. The low salt diet, again, that helps for the fluid in the inner ear. Avoiding MSG, that'll bring up something that we're going to get to a little bit later. Avoiding caffeine, not smoking, managing stress and anxiety, avoiding allergens, and migraine management and prevention. We're going to talk about vestibular migraine in a second, but there's some theories throughout the ENT community that a lot of Meniere's syndromes are actually a type of migraine. And we treat them with anti-migraine medicines that can actually prevent migraine headaches, and some patients do improve with that. Vestibular migraine is common. Patients with migraine have vertigo, much more so when compared to the general population or when we compare them to patients who have tension headache. The co-occurrence of migraine and vertigo is over 2%. Many migraineurs will have a history of motion sickness. Vestibular migraine can mimic a lot of the other syndromes we just talked about. You can have spontaneous vertigo as well as positional vertigo. You can have vertigo that's induced by head motion. You can have vertigo and gait instability that lasts anywhere from seconds to days at a time, and associated migraine headaches. The spells don't have to be correlated with the headaches. So you can have headaches on one day, dizziness on another day. Dizziness on one day, headaches on another day. And how exactly this works, the pathophysiology, is not well understood. When we're talking about vestibular migraine, again, it's often symptomatic relief. So we treat the acute attacks with medicines that suppress the vestibular system, so our antihistamines like Meclizine, our anti-nausea medicines like Reglan and Zofran, benzodiazepines like Valium and Ativan can all be helpful. The medicines that we use for migraine, like triptan medicines, sumatriptan or Imitrex, Maxalt, Relpax, Zomig, they are not effective for the dizziness component of the vestibular migraine. When someone comes in and I'm pretty sure they have vestibular migraine, so they've got moderately severe headaches that come and go, and moderately severe variable dizziness, my preference is to actually treat them with medicines that can help prevent migraine. So that's our prophylactic medicines for migraine, which include blood pressure medicines like beta blockers and calcium channel blockers, anti-seizure medicines like gabapentin, Depakote, or antidepressant medicines like nortriptyline, Pamelor, or Elavil, amitriptyline. Vestibular therapy can be helpful in these cases. It helps the patients adjust and gives them some coping mechanisms for when the vertigo hits. A lot of patients with dizziness, even though all of the conditions we just talked about are very benign, and these are our most common conditions, patients with dizziness are concerned they have something more significant. So are you having a stroke? So stroke can cause dizziness and gait instability, but usually not in and of itself. Lightheadedness, isolated vertigo is very, very rarely a stroke syndrome. Stroke symptoms come on suddenly, boom, kind of by definition. That's how we define strokes, sudden onset of a localized neurological deficit. We think about it more commonly in patients who have risk factors for vascular disease. So increasing age, male gender, vascular risk factors like high blood pressure, diabetes, elevated cholesterol, cardiac disease, atrial fibrillation, or a history of coronary artery disease and heart attacks, or if they're smokers. In younger people, we think about stroke if they've got migraine, if they take oral contraceptives, or if they've had neck trauma. That includes chiropractic manipulation and kickboxing or skiing injuries. And this is what people are concerned about, that they've got a blood clot in the back of the brain, in their vertebral artery or in their basilar artery that causes a major stroke. And on MRI, when we have a clot like that, you get abnormality in the brainstem and the cerebellum. And that's where those fibers from the inner ear, that's where those fibers carry information. So that's part of your vestibular system. If you have a stroke at the back of the brain in the medulla, which is the root of the brain as it attaches to the spinal cord, you have symptoms in addition to vertigo and dizziness and gait instability. On the same side of the stroke, you get decreased sensation in the face. That's why we talked about that earlier. We always check facial sensation. You can get involvement of the part of the autonomic nervous system, the sympathetic system. So you get a Horner syndrome. The eyelid droops, the pupil is small, and you actually could get decreased sweat production in the forehead. There's problems in the back of the throat, so trouble swallowing, a change in the voice with hoarseness, and a reduced gag reflex. There is a reason why neurologists actually check your gag reflex and make you say, ah. On the opposite side of the stroke, you can get decreased sensation in the limbs, and you get cerebellar symptoms and signs. So that's where the vertigo, nausea, and vomiting comes in, the jerky eye movements, the gait instability, and that's where you have that inability to touch the finger to the nose and touch your heel and run it down your shin. The head impulse test, so that's the one where we turn the head and we drag it back into shape, is usually normal in a stroke. Nystagmus tends to be fast, off to one side and off to the other side, and sometimes the eyes are actually in different position, called a skew deviation. And these are the hints to infarct. This is what we teach our residents to check for. So it's H for head impulse, H-I, N for nystagmus, and test of skew, TS. Those are abnormal, we're concerned that there's a stroke. In most patients with stroke causing their dizziness, they've got abnormalities on exam beyond their dizziness, their vertigo, and their difficulty walking. And most important, they get abnormalities in eye movement tests. So that's why we have people following the finger. That's why we're going back and forth with the eyes. Look at my nose, look at my finger. Subtle eye movement abnormalities are seen in almost 100% of patients who have stroke as a cause of their vertigo. Now, obviously, when we're looking for stroke and we're trying to figure out whether patients had a stroke or they have a peripheral vestibular dysfunction, so just inflammation of the nerve, we do that head impulse test. Look for it to be negative in a stroke, positive when we talk about peripheral vestibular nerve problems like vestibular neuronitis. We look at the direction of the eye jerking. Remember when I told you we were looking at benign positional vertigo? We put the head to the side, the eyes go jerky and rotatory, they move in like a little semicircle. That's again a peripheral sign. If it's going up and down, if we get it on one side and the other side, we're more concerned that it's a stroke. If the patient can stand with their eyes open, less concerned that it's something bad. If they can't stand with their eyes open and their legs together, we're concerned there's something going on in the back of the brain. Now obviously if you get an MRI, it's going to be positive in a stroke and negative if they have a problem with the nerve. CAT scans are not as good as MRIs at picking up these problems. So you got to kind of bite the bullet, go in the machine. I know it's noisy, I know it's closed, you got to stay still. But a CAT scan doesn't give us a decent enough view of the back of the brain where these strokes occur. So an MRI is the diagnostic test of choice. Okay, so my patient, I reassure my patient they don't have a stroke. The next thing they want to know is, do they have a brain tumor? Every once in a while, a type of tumor can cause dizziness and vertigo. It's called an acoustic neuroma or a vestibular schwannoma. So that's a benign growth of the insulating cells that surround the nerve. It tends to be slow growing. It's on the vestibulocochlear nerve, so that eighth nerve, that combined nerve that goes from the inner ear to the brainstem to the brain. We sometimes see this due to a genetic predisposition, so an abnormality on the 22nd chromosome. And it can also be inherited in a case of neurofibromatosis, which is a disorder that includes abnormalities of the skin as well as the brain. It's the elephant man, neurofibromatosis. Patients who've had low-dose radiation in childhood, sometimes to treat things as benign as acne, also have an increased risk of these kinds of growths. And you can see this tumor that's arisen here on the nerve. There's our nerve. There's the growth. And again, on a schematic, the nerve coming out of the inner ear, and you can add a growth on that. It's kind of fatty and tends to be yellow and bulbous. Patients usually present with hearing loss. It tends to be pretty gradual in onset, and it's progressive. And it's usually unilateral. It's one ear, because the tumor's on one side. They can have ringing in the ear or tinnitus, vertigo, unsteadiness, and facial numbness or weakness, because the nerve to the face that takes care of facial muscles is right near the eighth nerve, and same thing with the portion of the brain that takes care of facial sensation. On rare occasion, the tumor can grow large enough to be life-threatening. It can actually compress the brainstem, which is the core of the brain that takes care of our autonomic function, and it can cause hydrocephalus or obstruction of the flow of the spinal fluid throughout the brain. Diagnosis is done by clinical exam, a hearing test. If there's asymmetric hearing loss, so hearing loss on one side but not on the other, we send people for an MRI of their brain and their internal auditory canal, and we need to do it with and without contrast, so with and without an injection. And that tends to show the tumor pretty easily. In terms of treatment, small tumors are often just monitored and not treated surgically. We can do stereotactic radiosurgery, so that's focused radiation that attacks the tumor and shrinks it. And if it's large enough or in an appropriate area, the neurosurgeons can work with the ENT doctors and they go in and they remove it. In conclusion, we've got dizziness, vertigo, gait instability, common neurological complaints, many possible diagnoses, many of which are benign, very few of which are life-threatening. The diagnosis is made by the history, the neurological exam, and supportive diagnostic testing. And obviously the treatment is going to depend on the specific diagnosis. Your job as patients is to think about your dizziness so you can help your doctor make the right diagnosis. And that's it.